Well, here he is, Dr. Naveen Pemmaraju, first time on Healthcare Unfiltered. I am deeply flattered and honored that he is joining us today. For context, because we don't air this live, and I have to say that because things do change with time, we are taping this towards the end of 2021, about a week or so after the American Society of Hematology meeting. Judging from the schedule, we had our schedule, Naveen, was derailed a little bit. This might be airing towards the middle or towards the end of February, but we'll see how that goes. But look, we want to start by getting to know you a little bit. So Naveen Pemmaraju, tell us a little bit about you. How did you end up at MD Anderson, and what inspired you to become a hematologist oncologist?
Well, Shadi, thank you so much to you and for your friendship and guidance throughout the years. I'm a big fan of your work, including this podcast and the absolutely gems of breathtaking interviews you've done, in-depth analysis. So it's an honor for me to be here, my friend. Thank you. I think my journey really begins the moment that I started internship at Johns Hopkins Hospital. So I was an O'Slarian there way back in 2005 on the Barker firm. And Shadi, it was there that I really learned truly what it meant to become not only a doctor, but kind of an adult, I think is what I tell people at that time. My wife and I were quite young at that time. We had our first child while I was there. So that was a very special time in my life, and it made me into the doctor I am now. So that was 05 to 08. And then I've been at MD Anderson since then, chief fellow there in the 08 to 2011, and then stayed on for assistant to associate. I think the moment I knew I was going to be a hematologist was very young. My father and my brother both ended up being pathologists. And so there must be this common love affair of the blood smear, of the internal workings of the body. And my father used to take me into the hospital to look at the microscope. And what I gravitated towards was not just the smears, but the stories behind the smears, I guess. So who are these patients? Who were these husbands and wives, sisters and brothers who had these sometimes esoteric, sometimes uncommon diseases, and what is it that would work to treat them, to make them better? I wanted to be that doctor, so this was a very early age. And then, of course, as you well know, guidance, mentorship, pre-med, medical school internship. You have to be, shifted and molded in that direction and identify. And when I got to Johns Hopkins, Alice Somalaterno and Jerry Spivak there were the first two people that I met in my life that shared the same unbridled love and passion for hematology.
It's interesting you say there's thinking of the human story behind the slide. It's really well put. I really appreciate that, because there's a lot of stories, and once you are hit by an illness, your entire life could be derailed, right?
Right.
It gives you a lot of appreciation and perspective. So, so you've been at MD Anderson for 10 years?
Yeah, exactly 10 years. That's right.
10 years. And what's your role at MD Anderson? How do you spend your time, I guess, divide between, do you do lab, just research, inpatient, outpatient? What's the pie chart of Dr. Pemmaraju?
Yeah, that's an excellent question. And it's something that I would encourage all trainees and medical students to ask their attendings, because really, unless you ask that, you won't have a sense. So for me, my kind of weekly schedule, Shadi, is, so I would say about 60% clinical. I round on the leukemia inpatient service, anywhere from 2 to 3 months a year. And I have 4 half days, what ends up being 2 full days of clinic where I see patients in the heme leukemia clinic. And then the rest of the time dedicated to research, administrative, teaching duties. I would say one unique aspect of what I do, as you well know, is I've been recently appointed as the director of our program for blastic plasmacytoid dendritic cell neoplasm, or BPDCN. So I spend the majority of my time thinking about, writing, researching about rare, maybe ultra rare diseases and blood cancers, including BPDCN, and also patients with MPNs and acute leukemias.
And, the reason I brought you on is we're going to talk about rare diseases. So you're the perfect guest for the topic. I have a lot of questions about this, and we'll talk about this BPCDN, ABCDEFG, all that disease that we're going to talk about a little bit, because I'm going to take a wild guess, Naveen. When you started MD Anderson, you did not think you're going to spend your career on BPCDN.
That's exactly right.
Okay.
I think one of the great things about what we do is, we're all magicians who know each other's tricks, right? So, you go into, you want to be a doctor, I think first, that was the first thing for me, as I told you. Then which type of doctor, a surgeon or a medicine doctor, then hem-onc, then heme, then malignant heme, then leukemia, then rare diseases, right? But I definitely have to give a shout out to, for me in particular, it was mentorship, right? You have these doctors and researchers. It's not that you idolize them, but it's that you picture you want to be like them one day or do what they do for a living. And so I think you really hit it on the money that if you're open to new ideas, new opportunities, if you're open to developing that research niche area, not just for yourself, yes, you have to do it for career development, but something that causes spark of inspiration and passion, then it doesn't matter what it is you do, whether it's something rare or common. Do you have that life spark passion to go for it? And you're right, this is what I ended up finding, and it's been one awesome journey thus far.
We're going to talk about how you end up doing a lot of this research on it, and you published on it a lot, including the New England Journal of Medicine, obviously. But before we get there, let's just back up a little bit and talk about rare diseases. So, I mean, I know rare disease, orphan diseases. There's obviously a policy definition I believe, by the regulatory bodies on that. But how do you define rare diseases or orphan diseases? And I presume they're not really restricted to oncology or hematology.
Right, Shadi. I mean, this is exactly right. I love that you referenced there are these technical definitions that many of us in the field often don't know or don't use. There'll be classic ones such as from NCI, NIH, governing bodies, FDA even, whether it's 15 patients per 100,000, whatever these definitions are, a couple out of a million patients. But, we all know it when we see it. I think that you make two important points here. One is that there are rare diseases outside of our hem-onc worlds that are not only ultra rare diseases that may only affect less than 100 to 500 people, but they have yielded unbelievable breakthroughs that then can be used in other fields. So I think that's actually very important what you brought up. And then, of course, in our hem-onc field, sure, you have Castleman's disease, Rosai-Dorfman, Erdheim-Chester, BPDCN, all of these diseases which may constitute only one question a year on a hem-onc board exam, and yet affect anywhere from 50 to 1,000 people a year. And in the case of APL, acute promyelocytic leukemia or hairy cell leukemia, these have been paradigms for curing actually deadly diseases and leukemias, and then extrapolating them to others. So I love your point that yes, a rare disease, we know it when we see it, can be a cancer, can be a non-cancer.
But is the definition 15 per 100,000, or does it change?
Well, it's changing over time, so that's the technical definition that you can use when you're reviewing protocols or journal entries or even regulatory drug process. So I think that's a good benchmark. But I think the broader point is these are diseases that don't always belong in one category or the other. These are the diseases that change, WHO categories over time, BPDCN being the classic. It used to be classified as a lymphoid disease, then as a myeloid. Now in the latest, it's basically its own thing. And then I think also the concept that the general hematologist oncologist, whether in training or in the professional community setting, has either never heard of the disease, never taken care of a patient, or even after looking it up, still has no idea about the treatment history and paradigm. So I think that's the modern understanding, especially with information being so readily available now. So it's a very interesting, evolving situation where you can have a common disease and have a rare subset, have a completely new emerging entity, so such as this VEXAS syndrome that's come up, or a BPDCN, which has actually been around for decades, but the name has changed so many times, and it's kind of a hard diagnosis to make, long name. That can be the definition of rarity as well.
So, but is there, you mentioned about drug approvals. So is there a specific pathway? And I know, I
Yeah.
assume you're not really in policy research, but is there a specific pathway? If I have a drug that
Yes.
targets a rare disease, do I have a special treatment as a manufacturer?
Yes, this is actually a very important point, and I only know that because of what I do for a living. There is, and I've really would praise the US FDA in particular and the regulatory agencies in the European Union as well, which are the two that I'm familiar with. Absolutely, there is so-called rare disease or orphan drug pathway. What it allows companies, sponsors, investigators to do is exactly what you said. Once the declaration of the rare disease is made and verified, then there can be sort of a separate or emphasis pathway on that. You know, obviously it's going to have smaller numbers of patients. Clinical trial designs may be different. Possibly there's some involvement from the regulatory bodies early and often to guide the rare disease drug development pathway, particularly if it's a first in class. So I think what I've seen over the last 10 years is an awesome emphasis on this and a pathway and an ability for drugs to get approved for these very, very small numbers of patients.
Faster than the regular pathway and so on.
Oftentimes, sure, either through accelerated or regular, depending on the circumstance. Possibly, yes. Mm-hmm.
So, okay, maybe this is, and if it's a provocative question, but I'm pretty sure it's a question that is on the minds of listeners, because as you and I know, when you look at hematological disorders and oncological disorders, we have so much subclassification that is, that changes, almost becomes everything is rare. I mean, as you know, I've done a lot of work in lymphoma and CLL, and all of a sudden, I mean, Hodgkin, if you start dividing Hodgkin into, nodular lymphocyte predominant disease, and each one, classical versus non-classical, could become rare. Lymphomas, double hit lymphoma, be a rare disease because now you need to look at the MYC and BCL2 or BCL2 translocations, and it becomes rare. Even let's do solid tumors. You could look at breast cancer and you say triple negative breast cancer. I mean, the research in oncology and hematology is no longer, at least it's really migrating away from the broader disease and starting to look at subsets of diseases within the large umbrella. So I don't know, the cynical in me, I guess, or the skeptical in me, or maybe not cynical, I think is better. Suddenly all cancers are going to become rare.
Oh, this resonates with me very much. This may be the same for you as it is for me. One of the most common questions I get at social gatherings, dinner parties, especially prior to the pandemic was...
Prior to the pandemic, we don't want to, otherwise you'll get canceled. Naveen, you're going to hear that, they'll cancel you. We're trying to preserve you.
Yeah, and you're right. The social,
don't cancel
mores have
Not
changed.
mean that.
So, at these social gatherings prior to the pandemic, one of the most common questions is exactly what you said. Hey, when are you guys going to find the cure for cancer? And you've been given this question as well. This is actually what you just said. You're the first person I've ever heard to really say this so nicely. That's my answer. Is that there may not be one cure for cancer, as we all know. My goodness, even within heme and solid, as you nicely delineated, there's so many subtypes. And look at AML from the time, your lymphoid expertise at U of Chicago when you're on faculty in just these few years. If we look at the WHO from 10 years ago to now, unbelievable amount of subsets. So I think that what you said is important for three reasons. One is that, yes, I do envision the field moving even more so where classic diseases, like you said, like a Hodgkin's, are further divided not only to molecular subtypes, but immune subtypes, and then even a combination of all these so that we move away from necessarily heme or solid or named diseases, but pathway-driven diseases, right? I think that's important. Number two, the development of the field to target those diseases, which is a passion of yours, the so-called targeted or precision oncology, which we're already seeing in our midst. And then number three is no matter how rare or common a disease, and I love your example of breast cancer, which perhaps maybe 250,000 people a year diagnosed in the United States. But once you parse out the subsets, triple negative, HER2, ER, PR positive, maybe each subset only has 10 to 100,000 people. And now then you can actually have guided surveillance programs for that subset that may not apply to the other: cancer prevention screening, genetic analysis, so on. So again, to emphasize what you just said to me, there may not be such a thing as rare or common anymore the further we go with sequencing, immune subdividing. And at the end of the day, Shadi, what you're saying was close to my heart, which is, it doesn't matter if a disease is rare or common. It's your disease. It's your family's disease. It's your mother's disease, your father, you and your family are facing. So if it's N of 10 or N of 250,000, what you're looking for is the personalized guided therapy for what you have.
Yeah. I think the biggest concern I have is the regulatory implication, because once you have almost every disease as a rare disease, the barriers to entry for drugs that get approved are really much lower, right? Because for the accelerated pathway and for rare diseases, the barriers are much lower because the FDA allows this quote unquote unmet medical need for the rare diseases. So as a manufacturer, you get into the market faster. And I worry, it's good because you get access, but anytime you lower the barriers, I think the scrutiny in terms of regulatory is not as robust. And you know, I think the FDA needs to really worry about that, or make sure they put some guardrails. That's really my concern. My concern is if we start putting numbers on these diseases, then suddenly everything becomes, and especially in the precision oncology, like you said, market, like all of a sudden, are we, let's try, are we going to get to a point where we say, this is, you know, the MYC positive cancers, regardless of histology?
Right.
Precisely. You know, I mean, is that, you think we're heading that way with precision oncology?
Yeah. Gosh, yeah, this is a very provocative discussion because I really do. You and I are starting to see the beginnings of this that you're hypothesizing in some of the recent FDA approvals. I think the NTRK fusion approval is one, perhaps the KRAS story, perhaps some of these immune-based approvals are starting to be what's called tissue agnostic, which is exactly what you're talking about, pathway-driven. You have also this field of carcinoma of the unknown primary that we've all had patients with, where you don't quite know where the histology is. And in fact, identification of the molecular or immune landscape allows you, maybe you may not be able to identify the name of the parent tumor, but wow, we have this pathway ready to go. And then it sets the stage for CAR T therapy and immune therapy, where maybe we don't even need to know the tumor of origin or the pathway, but we have a potential curative approach, particularly in the lymphoid diseases as of now. So very, very provocative. And yes, I do see our field moving that way in the next decade.
Yeah. Yeah, I think I you know, it will be interesting to see. You know, you just made me think about something I may write about the definition of orphan diseases. We'll see. Excellent. But let's talk about BPDCN, or what people on social media call it the Pemmaraju disease. You know, I don't know. I mean, you know, you've arrived when people are not, you know, you've arrived when people don't know what the disease, they just associate the disease with you. That's, I don't know. Look, this is the time to retire. Naveen, it's going to, it's downhill from there.
Doesn't get any better than that.
I don't know. I don't know what you're going to do. I don't know what's going to happen after this. But maybe I think a lot of trainees and fellows might be very interested with this story because, you know, you and I know, you know, in fellowship, you probably never heard of this disease, just the way it is. How did this come about? How did you get involved in the research of this disease? Take us through the journey that led to, you know, drugs approved for this disease eventually.
Such a great question, Shadi. Yeah, so everything you said is, as usual, right on the money. So residency and fellowship, knew I wanted to do hematology, malignant hematology, thinking about the more common areas, MPNs and acute leukemias, which are of course still rare in many cases. It wasn't until the end of fellowship, early first year of faculty, where I had two patients, both younger actually, it's usually a disease of 65, 70, who both, despite optimal multi-agent chemotherapy regimens, passed away very early within a year, which was the historical expectation at the time, something like 8 to 14 months. And these patients had great therapy at academic centers, with all the latest multi-agent chemotherapy, et cetera, et cetera. So I
Leukemia?
presented.
They had acute leukemia?
So both of them had BPDCN, and as you said, they transformed to acute leukemia and died shortly after that. Exactly.
So for listeners, but tell them what BPCDN is, because
Yes, right. So that's the first time I came across the disease. So this is now 2010, let's say, at the end of the fellowship. So blastic, plasmacytoid, dendritic cell neoplasm. The B, of course, blastic, meaning these immature cells. Plasmacytoid dendritic cell, PDC, that's going to be the eventual cell of origin, which we did not know back then yet. And then neoplasm, of course, cancer. So a cancer of bone marrow blood cells. But what was odd at that time, Shadi, is that most of these patients would have skin lesions, dramatic skin lesions, purple colored, dark colored, all over the body, kind of setting it apart from almost every other leukemia. So that was one thing. The second thing is half the patients would have bone marrow blood involvement, like our lymphoma leukemias that we're used to. And then third, very importantly, was lymph node involvement. So skin, bone marrow, blood, lymph node. This sounds like a hybrid of cutaneous T-cell lymphoma, acute leukemia, and even other lymphomas, all of this presenting in one patient, oftentimes at the same time, oftentimes subsequent. So you're right. So that was about 09-10. And then the concept is this kind of nice story, which I'd love to share with people, which is presented it to my group and our great mentor and chairman, Dr. Kantarjan, who's always been very supportive. And, like you would imagine, he said, hey, we don't have any standard therapies. Why don't you take that up as your, your area, your research, and circle back to it. So started to look in the database. At that time, there were only less than 10 patients. They were oftentimes, Shadi, referred to either lymphoma, phase 1, dermatology, maybe even given skin-directed therapies for these skin lesions. But the uniform was that they all died very early, within 1 to 2 years. So that's part one. Part two is, how do you stake your claim in something when there's not very much known? And by the way, the name was only formalized in 2008. It had been known as blastic NK cell lymphoma, as you know, CD4 positive, CD56 positive hematodermic tumor. So just this panoply of names that further confused. Then the diagnosis was difficult, and then it's rare on top of that. Okay, so now part two is, I've declared to everyone, this is what I'm going to do. So how do you go about doing that? Wow, that was not easy. That was challenging. I do want to give two shout outs here. At that time, Shadi, there was a great collaborator of mine, Dr. Art Frankel, and his name should be said in this context. He was working on a drug at that time. He combined the diphtheria toxin to human IL-3. And he said, let's treat patients with MDS and AML. But this combination hits this receptor called CD123, a surface receptor. And so his vision was, why don't we include these rare patients with BPDCN? He himself had some, I had many, several other collaborators. So the trial went on for all three. The AML MDS was modest results at that time, but the real signal was with our BPDCN patients, where the skin lesions started to clear up, oftentimes within the first week. The toxicity was there, which we'll talk about, I'm sure, in a moment, which caused some fluid buildup in the heart and lungs called vascular or capillary leak. And then at that time, there was only one cycle of therapy available. So we did that for about 3 years, Shadi, and then we were able to publish that in Blood in 2014 with a nice editorial from Dr. Fitzgerald from the NIH, which said, wow, this is a promising field and a promising therapy, and it puts in a drug possibly to a rare disease field. So the CD123 sort of discovery that it was 100% ubiquitous overexpression on the surface of BPDCN, the development of a drug by an investigator, and then it leads to part three, which you nicely introed there. So now the company which got involved at this point, that was known as Stemline, which I and others have worked closely with over the last decade. They acquired this agent, now known as SL401 or TAG or tagraxofus, and we set out to do the first ever sort of prospective, multi-center, multi-cycle, proper phase 1/2 trial of this novel agent hitting CD123. And then, as you said, the rest is history. We were able to do that trial over about 5 years. And we actually, interestingly, we thought that the majority of patients, at least I did, would be relapsed refractory. So patients having at least one prior therapy in the community, but it was the reverse. People heard about this drug either through social media or online, self-referred or the doctors referred, the majority of patients were frontline. We showed a 90% at that time overall response rate in the frontline setting, 60+% in the relapse setting.
Wow.
And a lot of these patients, even though they were older, Shadi, they were able to go to stem cell transplant, and then that got published in New England Journal, and then the drug was approved in the US exactly 3 years ago to the day of this recording in December of 2018. So to turn it over to you, that's the kind of three-part story: is identify a need in your clinic, in your patients, develop a focus and a passion no matter what. And then I would say number three is be involved in all of the studies in your field, whether it's in the lab, in the clinic, writing review articles, writing case reports, writing database reviews, whatever you can do to both expand the field, but also to let people know this is what you're working on.
This is great, really great story. So what's the name of the drug for listeners?
Right, so the name of the drug, the first and only approved BPDCN drug in CD123, is known as SL401 or tagraxofus, or for short TAG. And this is with the Stemline Therapeutics company. And now it's exploded into a new field, CD123 targeting, as you know, in all of lymphoid and myeloid malignancies, with a host of other CD123 targeted agents in phase 1 through 2 testing.
So Stemline then got bought by Blueprint, or?
No, so Stemline is its own company. So the other rare diseases that you and I have talked about before, right? So Blueprint, that's the one with the KIT inhibitor in systemic mastocytosis, so on and so forth. So you're right. This topic is that there's a multitude of companies now either going for KIT, CD123, or some of these other targets in these rare and ultra rare diseases.
So you published this. You told us about the. Tell us about the results that were published in the New England Journal of Medicine.
Oh, sure.
Particularly maybe the duration of response and survival and so on, because I think that's really important. It's going to lead into the next question I have in mind.
Oh, excellent. Yeah, I think the most important things from the New England Journal paper, so that was April 2019, which I had the honor of leading and being the first author, along with my
Congrats.
colleagues.
This was really amazing. It's just
Yeah,
it couldn't have happened to a better person, truly. So
what a nice thing to say to someone. That means the world to me. Thank you very much. And as you know, also have to say, we both know as investigators in the field, it's a team effort. Really a lot of shout out to my two mentors at Anderson, right? Dr. Kantaraj and Dr. Marina Konopleva, her name should be mentioned here. And then Dr. Andy Lane at Dana-Farber. So, with this team approach, we got it into New England Journal. The most important results are, 45, just under 50 patients were treated, a mix of frontline and relapse refractory, but mostly frontline, 90% overall response rate. But that includes PR. So the CR rate, complete remission, was a very respectable 72%, which also included patients who achieved a CR but maybe had some unclear microscopic disease. That's called a CRC. And 45% of those frontline patients, that's 29 patients, were able to go to a stem cell transplant with a median age of 65 or over. In the relapse setting, it should be mentioned also that the results were markedly less, because these are now patients who've had at least one prior therapy. So there, the response rate was about 67%, but the overall survival was only about 8.5 months there. In the frontline setting, what appears to be we doubled or tripled the historical expectation. So I think the concept here was that in the frontline setting, extremely respectable results, which then went on to be approved in the EU EMA for frontline BPDCN. But in the relapse refractory setting, Shadi, I think the conclusion that I and others have is that still more work needs to be done. So we're investigating other CD123 agents, combinations. The duration and overall survival may not be there in the relapse setting. This is still a very aggressive, deadly disease.
So the duration of response in frontline was, is there a median duration of response? The 70% plus with CR?
Yeah, right. So correct. So what you can say is among patients who were stem cell transplanted, because that's where the longest term follow-up is, those were the fit patients. You're right. So actually, this is actually perfect timing. I just presented this at ASH, so these data are public. So at ASH, I showed the 1 year and 2 year survival probability. I think that's exactly what you're asking. Now, these are patients who were CR transplant was very high. It was 60% plus. So The supposition is that if you are able to get to a CR stem cell transplant, your 1-2 year survival probability is very, very high. But for the patients who are not, so older patients, those who are unfit, and I think this is exactly what you're saying, those survival probabilities were not very high. And I think the supposition there is that you have two different groups of patients, the younger fit patients and then the older unfit.
So this is the type of drug that is a bridge to transplant for transplant eligible patients, because the response rate is not going to last for long. If you are transplant ineligible, your response duration is measured in months, pretty much, it looks like, right? I mean,
yeah, I want to emphasize what you said, because in this disease, BPDCN, even with this drug and CD123 and all this excitement, still you have to say exactly what you said, which is allogeneic stem cell transplant in CR1 is still part of the mainstay standard of care, period. There are some patients who we put forward for auto transplant. You'll be very interested to know that with your lymphoid expertise. Usually those were older unfit patients, maybe skin only disease, but the field is still moving back towards allo. And then the second point you said is important, which is in the first remission. As we know in these acute leukemias, oftentimes CR2 may never come. Even if you get to CR2, the patient may not be in a good enough shape. So I think future directions will be combination therapies, central nervous system therapy to maybe try to eliminate stem cell transplant, but you cannot yet. That's correct. That 45% of our frontline patients on the New England Journal went to transplant. That's right.
yeah. Yeah, obviously the reason I ask is because philosophically, I wonder, I mean, like this was a phase 2 study.
Right, correct.
Obviously published in the most prestigious journal in the world, arguably, and then it did lead to a drug approval. Now, was a drug approved contingent on additional studies that you were supposed to do? Was this like an accelerated approval, and there was post-marketing studies that were supposed to be done afterwards?
Oh, good question. Yeah, no, this was a regular full approval. So it was not the accelerated approval, which is, as you're nicely mentioning, which would require that. So now the future directions, 3 years post-approval, I would say are threefold. One is the other CD123 drugs, so we have the IMGN 632, which is in furthest development. That's as a monotherapy. Number two approach is combination with the SL401. So we have multiple studies there, Shadi, in triplets. So the SL401 with Veneza as a triplet, and then SL401 with hyper-CVAD chemotherapy in Ven as a triplet. And then the third kind of new approach, I guess, outside of CD123 is HMA Ven, especially in the older unfit patients with BPDCN. So I think that's kind of the next 3 years for the field.
Yeah. And there's a lot of times where folks, for example, might say, well, you should not give a regular approval based on a phase 2 study. It should be compared to something, especially in the front line. I think the trial had some patients in the front line and some patients with the relapse disease. What's your sense of that? I mean, is it fair to say that you should have had the comparator arm to demonstrate that the drug even better than, I don't know, 7 and 3 or whatever?
Right. I think it's a very important point. And of course, this is something very important to me personally. I think, since I've dedicated my life to these rare diseases, the one thing I can say to the listeners out there, Shadi, and to our investigators, it's very difficult to find these patients with these rare diseases. We estimate the incidence of BPDCN possibly 500, maybe up to 1,000 patients a year in the US, maybe about the same number in the EU. And then for patients to be able to be referred to the academic centers, et cetera, as you know, and qualify for the study, very small numbers. So I think if you have an ultra rare disease such as BPDCN, very rare, I think in this case, it's completely okay to go for, in this case, it was a very well-designed stage 1, 2, 3, and then a 4. There was a continued access stage with regulatory oversight throughout, and then a nice historical comparison because we have the field comparison there. I think in the more common diseases or less rare diseases, absolutely, as you know, I favor, these important trial designs where you have a built-in control, built-in comparator. The other problem I will say in BPDCN, there was no standard of care approach when we first got into this. People were doing a variety of therapies. So even if you had a best available therapy or control arm, I'm not sure what we would have done back then. I think the last point also is in a disease that affects multiple disease compartments, as this BPDCN does, there were no response criteria. In fact, we had to put those forward and is now an accepted part of the field, which is basically an amalgamation of skin, MSWAT score from cutaneous T-cell lymphoma, Cheson criteria for lymphoma imaging, and then AML criteria for bone marrow. So to your point, we had to find the patients, do the trial, have some response criteria that was prospectively agreed to. So I think the question will be an open one for the field, but it's difficult to build in a control or a comparator arm in these ultra rare diseases when you don't always know what that arm should be or have the patient volumes for it.
Yeah, like before the drug, would you have given regular acute leukemia therapy?
Right. Yeah. So before the drug, so the trial started 7 or 8 years ago. So yeah. So let's go back to 2010. Let's say those two patients that I was telling you about. The two most common approaches have been ALL-based chemotherapy. So either hyper-CVAD Contorgen regimen or whatever ALL regimen your institution uses, and then dropping the doses, for older patients. Or, as you said, AML-based regimen. So the 7 and 3 most commonly used worldwide. There is a third approach, which is the CHOP-based or lymphoma-based regimens, particularly in some of the older patients. So that was the most common approach. Now, worldwide, right, the CD123 drug is only available here and in Europe. So for the rest of the world where I get calls and emails, those drugs are not available or the patient may not qualify anyway for that. And so there you still have chemotherapy, you have people using HMA-VEN, and we've published on all of these as well, and especially in the older unfit BPDCN patient.
You know, the clinical trialist purist may say you put investigator's choice, but I don't know. I mean, I know, it's such an ultra rare disease where
right.
you target to it. You could make an argument maybe in the older patient population that cannot get into a transplant. Maybe it's a philosophical question, but I could envision folks saying, well, you should do investigator's choice because there was an era before the disease before the drug was there. But in terms of the two things, in terms of the drug itself, how well tolerated it is, because obviously I presume it's very expensive. And number two, let's start there in terms of how well tolerated the drug is and so on.
Yeah, very important. So as we know, Shadi, with these new drugs, you have to look out for new toxicities, particularly first-in-class drugs. And we certainly found that with the tagraxofusp tag SL401 agent. So as predicted in that pilot study I described to you that we did with Frankel in 2014, we expected and hypothesized a vascular leak or capillary leak syndrome, maybe for different reasons, but that was part and parcel with the drug. So there were no grade 5 death events in the pilot study, but in the pivotal studies, we did see a couple of deaths related to the capillary leak syndrome. And I want to describe what that is because many are not familiar. Capillary leak syndrome is common in multiple different drug agents, either cytotoxic or targeted, sometimes in these bacterial conjugated toxins and even disease processes. So it looks like it tracks with albumin. So the lower the albumin or the faster the kinetic drop, then it looks like a patient may have this syndrome. And especially in an older patient, cardiac insufficiency, cardiopulmonary insufficiency could actually lead to death. So that was observed on the study. We quickly modified to have a screening for albumin. So you had to have albumin of 3.2 or higher. You had to have sufficient cardiovascular reserve, just by the usual parameters in most clinical trials. And then if the capillary leak syndrome developed, it needed to be recognized early and treated with albumin, Lasix, diuresis, steroids, et cetera. So with that, it was found to be very manageable, but appropriately so. Appropriately, it does carry a US FDA black box warning. So this is something that in the community setting, as it's now being rolled out, providers must know about beforehand, patients must be educated. Anyone can call me anytime if they want to. And then in our paper, we discuss this as well.
Which really is a natural fit for the next question because, not obviously every site is going to have the same resource and expertise as MD Anderson. So how easy to make that diagnosis broad in the community? Because frankly, You can agree with me that sometimes the incidence of the disease is contingent whether you can diagnose it or not, right? I mean, if you don't
Right.
know how to diagnose it, yeah, I'm sure it's rare, but it could be 2,000 cases versus 1,000 cases, who knows? So how easy is it to diagnose this disease in the community, as well as, frankly, other academic sites that are not MD Anderson, that have not seen the number of cases you've had? Um, how is it like the intersection between what you do and the pathologist does to make the diagnosis?
Yes, critical point. I'm so happy you brought that up here. Yes to everything you said. Let's go through it. So, I think about a lot about the Field of Dreams movie with Kevin Costner. If you build it, they will come. This is exactly right.
Yeah.
And we've seen this, you and I, in our careers, where you have a rare entity, rare disease, but then now you have one or two drug approvals, you have an NCCN guidelines, you have some awareness or something, and then now you have a treatment pathway. We're starting to see that in BPDCN. So first point you made, very challenging diagnosis, period, whether in an academic center or a community setting. Three reasons for that. One is the name has changed a bunch of times, probably 6 times over the last 40 years. So that makes it tough. Two is the diagnostic pathway, if you will, has not been standardized until now, I would argue. And then three is that there are other mimicking conditions. Well, let's go through that. Well, if you're in a community practice, you have a patient with a leukemia lymphoma process in skin. Shadi, you and I know most commonly that's going to be either cutaneous T-cell lymphoma, AML leukemia with leukemia cutis, maybe even CMML with extramedullary manifestation PDC. So you have to know what the differential is and be able to order the appropriate test. In this case, CD123, 456. So I tell people think 1, 2, 3, 4, 5, 6. That's not specific for the disease, but it's sensitive. And then I want folks to add in these specific markers, TCL1, TCF4, CD303. The second aspect is that you need to be thinking about the disease brilliantly, as you said. So if you're not thinking about it, you're not going to necessarily order these special stains and tests. So education, awareness, programs such as this, HEMONC, board education, pathology, dermatology, right? This is a disease that involves the skin and pathology. So it's actually a little bit broader than our usual clinical HEMONC fields. And then finally, the WHO has been fantastic about trying to reflect this. If you look at each of the revisions, and as you well know, especially when you were at U of Chicago, with some of your pathologists being the lead of these, is that the revisions are very helpful for pathologists and other folks making the diagnosis. Okay, now it's under myeloid. Now it's under its own category. We need to check these tests. So I think you're seeing all of that happen, but even at an academic center, it is still difficult to make this diagnosis. You have to separate it from AML, leukemia, cutis, and others. Finally, I think the last point you made is so huge, which is unless you are keeping up with the literature, you're not going to know about these rare diseases. Again, I'm going to use this VEXAS syndrome, which is something you and I have been following. This was New England Journal about a year ago, actually exactly a year ago, December last year. BPDCN, VEXAS syndrome, they've been there. Now we're just giving names to these diseases. We're giving them a face, a diagnostic pathway. And you're right, when you have a New England Journal or a drug approval, as we're fortunate to have in BPDCN, it should put the education and awareness at a premium, but that usually takes 5 to 10 years, doesn't it, for a new or newer entity? So I guess that's my take-home point for that question.
So Naveen, I want to finish a little bit with some advices that you would give to listeners, maybe mainly trainees, and I don't know. I'm not gonna consider you junior faculty no more. You're too old for that, and you're too accomplished for that. Old in a sense, not age, but old in the accomplishments you've done, obviously. But for folks who are entering the field and students, fellows, or junior faculty who may be interested in some of these, I don't know, it's hard for me to believe you would be interested with it immediately, but things do evolve. So I guess when you take your career and put it to perspective, what advice do you give to trainees and junior faculty as they embark into an academic journey, which is different in terms of the scope and the goal than a community oncology journey?
Wow, you asked the best questions. And even after this interview and program, I'm going to be thinking for the next few weeks about how lovely this discussion was. I think this is the right thing to ask. I think I have some serious things to say out there because, with this pandemic and the change in the work-life environment for many of us, we've had time to either electively or, be forced into thinking about these questions. My advice would be this to all the trainees out there who are looking to be academic investigators. And of course, I should also let the listeners know, I haven't been in the lab for a long time. So I'm a clinical trial investigator, medical educator, physician. I don't know, 3 or 4 things come to mind. Number one is to find your passion area and to not be afraid to pursue it, even though it's quote unquote not on the main course. Obviously, in this hour, we've talked about my path, but there are very similar paths that people can take. And it's not uncommon to hear someone say, oh, you're throwing your career away by doing that. So follow your passion in the sense of if there's a new area or an emerging area and you actually are interested yourself, not because someone told you or assigned you to it, maybe you're driven as I was through patient care outcomes to learn more, whatever it is. So I would say follow that, even though it may not be on the main pathway, but then number 2 is to become an expert in it. Becoming an expert, I found, is this combination of daily drive, plus I would say writing endlessly about your topic and submitting to anywhere you can, not just abstracts. Abstracts are good, but manuscripts, reviews, papers, case reports. And then 3, be the best collaborator you can be. Somebody has a clinical trial in your area. Yes, I would love to participate. Someone has a patient that they need help with. Yes, I would love to weigh in. So I think not only finding your passion, but putting in the hours, right? The 10,000 hours to become an expert in something. Then number 3, I think this is very important, is find great mentors and be a great mentor yourself. So oftentimes that, you're right, I'm at that point in my career now, and you're making me reflect on this, which is I've had these great mentors, some of which I've named, by name here. And now I'm at the point, as I'm talking to you, where I'm starting to mentor the next generation. And that fluid process, I would argue, is not only a great thing to do, but it's a sacred necessity part of our field, which is the see one, do one, teach one philosophy. By reading, writing, learning, become an expert, now then, I believe, in my opinion, you're obligated to do that, to teach the next generation. And you know that I believe in medical education a number of ways. So one way you and I are able to do it with our followers that we've developed over time is through social media. So Twitter, programs such as this, which are important to get the message out there, and then writing. Whether it's an op-ed, as you mentioned, you've written some beautiful ones over the years, review articles. That's where the patient referrals come from. That's where the invitations come from. So then that starts to snowball and avalanche. So I would say that's kind of my advice, but it doesn't always have to be that you have to follow your mentor's exact path, but you should find your own path, become an expert in it, stick to it, and then start to mentor the next generation. I think, Shadi, I think that's what's worked for me, and I think that may work for a lot of folks out there.
I appreciate that, Naveen. I also appreciate truly the fact that you mentioned mentors by name. I think it's really, really, really nice. And I think there are mentors that definitely have an impact on someone's career. And I think, when you sit back and reflect, you realize that your career is shaped by many people you meet, right? But there are always like 2 or 3 people that they've done really something amazing. And I know Hagop personally, and he's really an amazing guy. The other thing I would add, and I wonder what you mentioned, I do mention I do also appreciate you mentioned social media and so on. But the one thing I would say that this pandemic has taught me, because we were able to do a lot of things virtually by Zoom and so on, I think there's an opportunity for virtual mentoring. And I think that oftentimes, for example, you're at MD Anderson, you probably are going to mentor residents and fellows at MD Anderson who are going to come to you and say, give me a project, can I be involved, and so on. But you may get an email or a text or a tweet from somebody who otherwise have never actually met, a student, a fellow, a resident, that is really looking for something to do. They have the drive, but maybe they don't have the resources that others have. And I've made an effort to respond to all of these.
Wow.
Sometimes I don't have much to add, but at least I'll respond. But I really think there's an opportunity for us to do virtual mentoring to people that they
Awesome.
may reach out. So I presume, do you get a lot of these? I mean, you're very active on social media. Do you get people
Yeah.
who are not at MD Anderson, maybe at different institution, not as well resourced? They're seeking projects with you and research ideas?
Yeah, I love that you brought this up. It's such an important thing. And I think you and I and Ruben were talking about this when we met recently at the ASH meeting. Ruben Mesa has been exactly that for me. We've never been at the same institution, and yet we've been linked through the ASH CRTI, which I should give a shout out to. It's exactly what you said. They sort of invented virtual or remote mentoring way before we were doing it in this pandemic. What Ruben Mesa has done for me is what I would call friendtorship. It starts out as the classic mentor mentee. Hey, I have this review article. Can you write this for me? Can you work with me on this? Sure. And then it evolves over time as you become colleagues to let's do this clinical trial together. Let's host this conference together as Ruben and I are doing now. Now we've become friends. So this friendtorship model, as I call it, I think is one of the key sustaining aspects, particularly during this pandemic time. It's kind of a non-threatening, non-intimidating way to have someone who's senior to you and who's been through the process and say, hey, what do you think about this? I got this invitation, write this, or hey, you want to do this together? So I think that's key. Now, for me, as you're right, I am starting to get those messages. It's been very gratifying. You're right. Twitter, for both of us, people DM us, direct message. And it's been one of the most kind of unexpected joys, I guess I should say, of this difficult time for us these last 2 years in the pandemic. I really cherish that. And I think anyone who knows me knows that because I am one of these pay it forward kind of people. So yes, if you're a student out there, trainee, interested in rare disease, leadership, reach out to folks like you and me because you never know where that's going to go. You never know. It may lead to a review article. It may lead to a job interview, or it may lead to a lifelong friendship or collaboration. And as you and I call it, you can meet on Twitter first, and then IRL, as the kids say, in real life, okay? In real life.
I like this friendship. I like that.
Friendtorship.
I like that. I like that. Look, Naveen, this has been really such a pleasurable hour. I can't wait to air this. Lots of nuggets in this conversation. Any last thing, any final words you'd like to say to viewers or listeners? Because you are going to be on the YouTube channel, Shadi Nabhan and Healthcare Unfiltered.
Oh, wow.
So it's good you're wearing your tie.
And I should say, this is my Osler tie.
By the time this airs, you'll get a very amazing, wonderful T-shirt.
Oh, wonderful. And you know that I'm a big fan of yours and that T-shirt. No, I think the biggest message, and you said it kind of earlier, what I've reflected on the pandemic is it's not enough for us as scientists, researchers, and experts to only do our research in silos and to write our review papers and manuscripts and then to call it a day. I think what the pandemic has taught us and what we have seen together is that research and scientific exchange of ideas, particularly in these rare of the rarest diseases, must go on. They must continue in some way, somehow, virtual, remote, online, if it's safe to do it in conferences, but it must be a concerted, shared effort. Folks like you and me who understand the traditional media and now the newer media, because I'm telling you, if we allow ourselves to not continue on with the research, not continue on with the science in these rare diseases, then people will be affected by that. I'm so proud of my group and the community. We've somehow been able to continue clinical trials, remote consenting, IRBs, FDA, everyone figuring out new ways, Shadi, to be able to keep clinical trials moving, drug approvals. And I'm telling you that this is going to be one of the great stories and impacts of the pandemic, that we were able to continue the majority of our rare disease research despite difficult times. And for that, I want people to know that there's a lot of hope, even with tough times.
Well, Naveen, thank you. Although you keep lumping me in with you and I think you're way more popular and you are way more prolific on social media. So I appreciate you putting me in that category. I don't think I deserve to be in that category, but I appreciate the gesture. Well, thank you so much for coming on Healthcare.
Thank you, my friend. Thank you so much. All the best to you.